We lost black shirt. What do you think is the diagnosis of this patient? This adult patient. Obviously, it is not. We established it from the So what is this case? Now obviously it will be some sort of fixed because the stomach is infection leak. So your thing is okay, reasons for that? No, that is first of all. Your answer, Parth? Asking again question, answer will be very easy. Logically. Okay, what is the correct answer? And the reason for that? No, correct answer. Why? Today also will have here. One second. Forget the marrow report or the clinical picture and profile. So one organ, what more? That nodules which you don't get in Filaruasis. Okay, do that. What is the striking feature? Increase appetite and weight loss. This combination how many times you get? Tomorrow you see a case of TB, what will be the complaint? Loss of appetite and loss of weight. But what is happening here is, on contrast, the appetite is significantly high. So Kala-Azar or Leishmaniasis has one notorious finding which you don't get in any other infection. The appetite will be crazily high, but there will be loss of weight. So it is a chronic disease, almost similar to TB. Same symptoms of fever is there, weight loss is there. But the only difference you will find is these weights will have a voraciously bad appetite. So this image probably shows some nodules are there in the face, and this is the, we are showing lot of agglutination. It's not showing in healthy bodies, basically showing lot of agglutination. You can see the RBC is all clumped, so roulette formation is more. So what is one more factor of a feature of chronic infection? One more specific feature of chronic infections, you don't get that in acute infection. Anemia. Sometimes public comes in typhoid, comes in malaria. One notorious finding you get in chronic infection with regards to say biochemical profile and CBC, but you don't get that in acute infection. What is it? Okay, so CBC is showing opposite prominence. Okay, one. Second, in biochemistry, albumin will fall down. What ma? You only said albumin something. Yeah, you're right. What happened? Remember? Albumin. Wait. Why albumin is below? Remember? The right answer is combination of both. So there will be a reversal of albumin globulin ratio because of a significant polyclonal hypergammaglutinemia. And albumin will be low because it's a negative acute phase reaction. So they will have a combination of low albumin and increased globulins. This increased globulins will cause this formation of globulin. So these are the two things you get in a chronic infection. And one hallmark feature is this increased appetite. And this marrow, or you can see loss of amastylus inside the macrophages. So this is a case of Leishmaniasis. Fine, so we'll discuss now Filaruasis. So who's from Karaikal? Hey, Karaikal है? मतलब who's Karaikal? आप कितना Karaikal है? हम बोला. क्या में लिया? हाँ, बोले Karaikal दे रहे नहीं? सुनो लारा. हाँ, कौन ले लिया? Okay, what is famous in Karaikal? Alva. Temple ले आता हूँ बोला. What are the types of Alva in Karaikal famous? Root alwa then. What is the root put in the root alwa? Alva So, filariasis is a common disease, predominantly the central part of Tamil Nadu, Nagapattinam, Mayiladuthurai, Tanjavur districts, and Karaikal district is found. And obviously, it is a disease predominantly affecting your lymphatic system. It is because of this adult worm being in the lymphatic vessels. With release of this microfilariasis will cause significant fever. There will predominantly a nocturnal rise or evening rise of temperature every day, and these MF circulates in blood. And it is one of those mosquito transmitted infection. Which mosquito? Kambi balla kadise sollu pa nagatha kadise sollu. Ayu only. Allah give me say muruthu. Come on. What is the mosquito responsible for? You are a Adis fan. Supapadi. Come on. Which mosquito man? Pulex. So it's a Pulex mosquito transmitted disease, and common in our area is mainly these two species, which belong to FT and Rugia malaria. So what will be the primary thing you will find the clinical smear in these people is all these microfilaria, which can be seen during the times of fever. So you have to make a smear during the times of fever. You will find this MF circulating in your blood, and if you do a nodal biopsy or a lymphatic assessment, you will find the adult worm sitting into that. So basically the primary problem is adult worm in the lymphatic system causing occlusion or poor drainage of lymphatic system, leading to all those secondary findings, edema, which may go into stage of lymphedema, and this vessel in the lymphatic system getting inflamed, causing what is it called, lymphangitis. There will be lymphangitis, fever, and there will be thread-like finding along the roots of lymph tissue. This is adult one where you can find this 3 seen across the lymphatic vessel. So basic pathogenesis of this organism is occlusion of your lymphatic system and release of microfilaria. That's all. So these are the 2 primary game players to cause all these symptoms. And the vector is Pulex. What is special about Pulex? Why only central part of Tamil Nadu is affected? Nappa garba satta solupa. Black shirt. You are only wearing black shirt. What is special about Pulex in comparison to other mosquitoes, you know? Okay, what all mosquitoes you know? Anaplex mosquito, then? Aedes. So what is special about Aedes?
Aedes will have
strips. So it's a tigeroid mosquito. Okay. One more special? Angle it bites. Okay, what is that angle? Acute angle, obtuse angle. What angle? 40 degree. Maybe you are supposed to read here. Aeronautics, sir. Say, sollu. Mask pota thambi. Aedes is special. Water body. What water body? Artificial water body. Okay.
Speed and multiple bites.
Multiple bites. What mosquito one bite after today 1 bite. After that today rest. Only 1 meal per day. Okay. 3 hours rest, 4 hours rest. Hey, what is special about Aedes, man? Daytime biter. So Pulex is special. Soliya, munju senjite sollu. Pulex is special. Night time biter. Yana plus night time biter. So what more special? What is the water on Pulex breathes? Dirty water. So, அப்ப இந்த 4 சீன் dirty water இருக்கா பாண்டிச்சேரி இல்லையா? நாளைக்கா தம்பி இந்த கேளியை கேளு. உன்னை பார்த்து நான் ஒரு கேள்வி கேட்கணும், திருப்பி இந்த கேள்வி கேட்கணும்ல. பாண்டிச்சேரி டிச்சு ஓடுது. இங்க வரல. So it needs almost some temperature also favorable to that. So quite often you find dirty water going in the delta districts. Not sure what is the reason, but it is very common to find this in the dirty water. So this mosquito, especially Pulex, is mainly the primary organism or like vector for Fuchsia background. So most of the times they can be asymptomatic, especially in the endemic regions. But otherwise they can have symptoms related to lymphatic system inflammation, which may be pain, tenderness, and enlarged nodes. And because of release of microfilaria, they can have fever. And based on the area where there is obstruction, there will be lymphedema. Predominantly in the peripheral areas it's common, and also in other areas like genitals and breast. Along with this, what does the group of disease this filariasis belongs to? Like bacterial, viral. தம்பி சொல்லுப்பா இது தம்பி நீ கரூர் தம்பி தானே நான் சொல்லுப்பா உன்னையா ஊர்ல தண்ணி நல்லா வருதா சிதம்பரம் நல்லா இருக்கா தெரியுமா வர சரி நான் சொல்லு which group this disease filariasis belongs to? organism means bacteria, virus, fungus, நீங்க எந்த group belong to? ஏன்னா மைக்ரோபயாலஜி ரெண்டு சொன்னாங்க படிச்சீங்க we forgot that earlier. It comes under parasite. Parasite ல எந்த parasite? Nematoda, cestoda. You answer correct nematoda. So what is special about parasite infections in terms of CBC? Abhi glucose center sensitive group. Ne special CBC என்ன தெரியும்? தெரியலையா? What do you say find the CBC in patient with this? I'm put an answer. Easily, so basically, all parasite infestations will cause significant activation of your TH2 system. There will be a lot of eosinophils and hyperaging. So because of eosinophils, they can have symptoms related to eosinophilia. That is all your reactive components. There will be reactive yeast. You can have allergies. So these will be another symptom that can happen because of elevated eosinophils. So these are the symptoms what you will get in a patient with filariasis. So striking feature will be lymphedema. The lymphedema is primarily because of stasis of lymphatic tissue or lymphatic fluid. What will happen in fluid stasis? In what way lymphedema is different from venous edema? Okay, not fitting. Why is it not fitting? Yeah, not fitting. So yeah. Yeah, bright area. Not you. Jayakumar, what is the difference between venous edema and lymphedema? He said it is not fitting. Why is it not fitting? Must be some reason, right? That is known, man. Lymphedema comes because of obstruction of lymphatic tissue. Venous edema comes because of poor venous drainage. It can be again obstruction also by strong lymphatic. Maybe then you will start. You can't want to answer. That's why you can't work, right? No. Answer, come on. Hey, what is the difference in lymph fluid and venous fluid? Man, what is the difference in the content? It is protein rich. So what will protein do? Protein has lot of factors that will promote fibrosis. There will be lot of reactive fibrosis. Because of the reactive fibrosis, you get the thickened field. That is why it is not fitting, and you can't displace the fluid that easily because it's going to be slightly something like a coagulated fluid. What is the TB finding? CS of TB finding. Sulia. You take CS of fluid of TB and keep it for some time, or you take a pleural fluid of TB and keep it some time. What will happen? Why the compound is formed? Proteins. They all coagulate. So similarly, the coagulation happens in your soft tissues. That is the reason you are not able to displace the fluid, and also there will be a reactive fibrosis of skin which makes it slightly thicker. So these are the symptoms you will get. So the lymphedema can be as bad as this, or can be as the starting point like this. You can obviously find the skin in comparison to the left hand, it is quite more thicker appearance wise. So this is what will happen in a patient. So now to diagnose filariasis. Nabi, who can say the mask correct under? How many infections are there? How to diagnose? When you ask about diagnosis in exam, what do you write first? CBC, pass 100%. What will be there in CBC and spherical smear? Eosinophilia will be there. Okay, 1 mark. Let's me will show microfilaria. Okay, class 1 right. Second, what else you could do? Yeah, again one. What else you can do? So when you can do a CBC, which may show eosinophilia, you can see for microfilaria. In either tissue or substance, you can take lymph node. So you can go for a lymph node FNAC by lymph node biopsy, which may show RSOM on excision. So only these two things are needed. Beyond that, we have serologies of filaria. So this may help in Diagnosis of carriers. Another presentation of filariasis sometimes can be isolated eosinophilia. What is IHES? What is CE circular particular setter? That is green, you know, setter? Yes. You are the only person that has green shirt. What is IHES? Idiopathic Yesana syndrome. Now what is in between H and D? You know any other H and D? What is the other H and D? Some stain is there, man. H and D stain. What is that? Okay, so no anybody else wants to want it? H and D na. E na சொல்லிடலாம். eosinophilia. So H na. Hematology eosinophilia. Eosinophilia is hematology only. So it can be pulmonological eosinophilia. Hypereosinophilia. So another presentation of filariasis, especially the asymptomatic people, can be IHES, where they will have unexplained eosinophilia. The primary presentation will be lot of reactive problems. They will have lot of V's. They may have cardiac enlargement because of endocardial fibrinolysis. So those things can also happen. So you get a case of unexplained eosinophilia, and if they are from central part of Tamil Nadu, at least I am not sure of the north, you think of filarial disease. So diagnose, if you do many times as near, you may not find them. What you will find them in is only filarial graphs will come positive. So these are the investigations you can do. How to treat? Yeah, treatment சொல்லுங்க. சொல்லுங்க. What is the treatment? Right. Yes, right. So as on date, there is no clear prevention strategy is not clear, but they do something called as mass drug administration, where both DEC and albendazole is given. Basically, DEC will kill the microfilarias, single dose is enough, and albendazole is primarily to kill the adult organism. And obviously, anti-vector measures, make sure you know what the storage, all those things, what you routinely do for any mosquito. Then you put that DDT, all those. Campus they put no every 2 weeks once some possible that you can try. And obviously treatment is DEC for 2 weeks. That is one option, or you can go for ivermectin or albendazole. Preferred one is DEC because it's more organism specific. And second thing you have to do is for lymphedema. What do you think will be the possible treatment for lymphedema? Sulupa bacha seta. Niya pala treatment lymphedema. Any edema, how will you treat? Diuretics. So this edema will not go because it's not fluid. That is because of increased hydrostatic pressure. This is because of local increase in oncotic pressure. So diuretics will not work. Anything you will edema, one more thing you will do. You will have to elevate yourself, man. Clue kodutha sollu. Limb elevation. So you will have to do whichever area is there possible to do elevation, you try to do, but still not be good enough. What more you should do for lymphedema? It is protein rich. So what you should do? Yeah, protein rich fluid. To reduce the protein, what you can do? Anything you can do? Nothing you can do. So you will go for compression stocking. So compression bandage and limb elevation is the earliest one you will do before the skin has gone for not much of thickening. But still it gone bad, then you have no choice but to go for surgical corrections only. So with this, filariasis is over. Any KV? No KV will go to leishmaniasis. So what is leishmaniasis? It's a protozoal disease. One peculiarity about this is it's almost seen in the central and eastern part of India, and it's because of sandfly bite, and it is a hemophagolate named Leishmania donovani. So what is so special about leishmaniasis apart from what we discussed? Solupa kattapoda satta. What is special about Leishmania donovani? Which organ system of your body is going to be affected with this LD? Lympha. That's more tapping. You can't repeat the same tapping. The clubbing is like this. You don't club to one lymphatic disease and another lymphatic disease. So lymphatic disease out. You answer MCQ like this. No. First question is this, the next question cannot be the same question. No. Use that logic and say. What is RES? So it is a disease primarily affecting the RES system. Why? Or which all diseases can affect RES? Or what sort of disease can affect RES? The organism proliferating in some part of your body can affect RES. Which one? Yeah, RES is liver, spleen and node, and that's fine. My question is, organism should have a character which can make RES hyperplasia. Say other disease is RES hyperplasia. Some other disease. Malaria, okay. Then bloodstream infection. Klebsiella pneumonia is bloodstream infection. Staph aureus is bloodstream infection. You don't know liver and spleen is that. Yeah? They'll get sequestered there. Why is saying sickle cell anemia? One more disease starts with S and ends with S. So basically, you will have to have an organism which is primarily going to proliferate within lymphocyte. Then those are the diseases you will have RES hyperplasia. This is one of the disease where it will proliferate within the lymphocytes and your macrophage system. So as soon as the bite happens, the organism goes in human stage, it will there. Primarily, if you see, it will multiply a lot of the times within your macrophage mononuclear system. And all those amazygote, chromazygote, all those mazygote stages happens. And then amazygote stage is the infective stage where it goes inside the sand fly, does all those multiplication, and then comes into your body as chromazygote. So what you find particularly in these fellows is, it is primarily going to multiply in the macrophage mononuclear system. Why is it multiply there? Obligate intracellular parasite. One, by doing that, it can escape from the immune system. So how to destroy an organism with the macrophages? Which part of our immune or which cytokine is more important? How many cytokines you know? How many cytokines you know? Cytokine தெரியாதா? நீங்க அந்த மாதிரியே இருக்கேன். ஒவ்வொருமா சிரிக்கிறான். நான் சொல்லியா. உனக்கு தெரியும் நான் கேட்க போறேன் திருச்சினே இருக்கேன். நான் சொல்லு. இந்த cytokines சொல்லியா? இன்னொன்னு நீ cytokines. ஒண்ணா? ஏய் அது எண்டிங் ஸ்டார்டிங் சொல்றா. There is always going to end with 1 and 2 3 5 25. Interval again. Interval 1 2 3 4 5. நீ பாஸ் ஆயிரு எக்ஸாம்பிள். நெக்ஸ்ட் only interval வேற ஏதாவது சொல்லியா? ஸ்டார்ட்ஸ் வித் D and ends with F. D ன்னு ஒண்ணு. ஸ்டார்ட்ஸ் வித் I and ends with N. அதுல F வரும். நாலு கேள்வி கேட்டாலே நான் தான் பதில் சொல்றேன். So primary thing you need for killing these organisms with the macrophages, you need to have a lot of interferon gamma, because interferon gamma will activate your macrophages. So somehow or other, this organism makes sure your body does not have adequate interferon gamma for reasons unknown. So this will happen, and as a result of this, they will proliferate inside your mononuclear macrophage system. And these mononuclear macrophage systems are primarily there in your RES, so there will be hyperplasia of these areas because the body is trying to kill but not able to kill. So they go for more and more hyperplasia. That is, more and more liver and spleen and more macrophage involvement inside the marrow, but nothing you will get as an output. Patient will have continuous fever. So what will be the finding is high grade fever. The characteristic feature you will get in Kala-Azar, you don't get in many other diseases. You will get high grade fever going on for months together. Why is it going on for months together? Any reasons? Any hypothesis? Rabi, phone nodi pidichiya? Na score ah? Increase istangala. Why is there high grade fever? Sorry. So why is not diagnosed on day 1? Why is it taking 2 weeks? Incubation period is 2 to 6 months, then you are diagnosing after some 2 or 3 months. Why the doctors diagnosing Kala-Azar so late? Is it our inefficiency or the organism is so very clever? All of this multiply only. Malaria also multiplies. But malaria are diagnosing in by day 4, day 5. Malaria also diagnosing by day 10, day 15. Strep is diagnosing by day 10. But I am saying Kala-Azar is diagnosed after months. Why? That they are diseased. I am not diagnosing tomorrow. I am diagnosing after 3 months. Basically, our common test doesn't diagnose this. What are the common tests you do? CBC. CBC will not pick up this. You do RFT left, you will not get any clues. The only thing you will have is fever. Malaria, do a smear, you will get a diagnosis. Filaria, do a smear, you will get a diagnosis. You do a serology, stop getting diagnosed. But in Filaria, Leishmaniasis, you don't get any clues externally. You will get only finding is increase in liver and spleen. When you get increase in liver and spleen, what are disease you think of? Fever, liver and spleen. What disease is it? Leishmaniasis is it. You exam pass. Hey, malaria, man, you not think of malaria, you think of scrub typhus, you not think of typhoid fever. So these things you think. By the time you investigate and evaluate for this, and you get all those tests negative, another 1.5 or 2 months will be over. You get fever and you will think of malignancy, you'll be doing a bone marrow. So that is where either doing a bone marrow or by chance you do an RK technique because of epidemiology, you may get cancer. So what will happen is these fellows will have high grade fever and a massive splenomegaly, and there will be a lot of cutaneous changes, mainly in the form of hyperpigmentation and cutaneous nodules. So these are things that will happen, and specific finding is this appetite. So always when you have a fellow coming from middle part of India, especially middle and east, then think of Al-Azhar when he is having a massive splenomegaly or moderate splenomegaly, and specifically appetite is good, think that it can be Al-Azhar. So how to diagnose? Either two options, you can go for histopathology, like doing a liver biopsy, bone marrow biopsy, all those things where you find the EMS you has shown in the initial one. Another test you can do is RK13 antigen, which will be positive. So these two things are the better way to diagnose. Other findings you may have is, you will get all those initial smear findings, like agglutination can be there, true formation can be there, polyclonal hypergamma can be there. So these are the findings you will get. And obviously how to treat? Drug of choice is liposomal amphotericin, or if not available, at least amphotericin. The duration to be given is at least 4 to 6 months. Another added drugs you can try is sodium siboglutamate, and obviously vector control measures. So I use like in management, the drug of choice is amphotericin. Miltipocin, sodium siboglutamate, and all though it is theoretically there, we don't use. What is the disadvantage of using amphotericin for this long? Nephrotoxicity. What has been nephrotoxicity because of amphotericin? Part of kidney, Solia. What are the parts of kidney? Like microscopic structure of kidney. Long parts of the Bowman's capsule. Okay, that's glomerulus. PCT. So what will be this area where amphotericin damage? Is it glomerulus? Is it PCT? Is it DCT? Or it is collecting duct? Which area? Nambi topi pota nambi suluba. What are 4 choice? Which area will get affected? Glomerulus, PCT, DCT. What will happen if glomerulus is damaged? What will be the symptom? Filtration problem. That is pathology. What will be the symptom for that patient? Increase urine output. Say a diagnosis which will have a glomerular damage, a glomerular disease. Disease. Glomerulonephritis. What will be the symptom of glomerulonephritis? Polyuria or oliguria? You said more urine. So glomerular damages will have only 2 or maybe 3 symptoms: oliguria, plus minus hematuria, plus minus proteinuria, plus minus hypertension. So this will not cause glomerular damage. It will cause tubular damage, primarily proximal tubule and distal tubule. So this will lead to tubular dysfunction, leading to renal tubular acidosis, hypokalemia. So these 2 things will be there, and as a compensation, the child will develop hypertension and also will develop rise in creatinine because of tuberoglomerular fever. So this will be the problem. And how to overtake that? Either you have to modify that to your amphotericin, which is liposomal. That will reduce your concentration of the kidneys, but still not 0, but lesser than plain amphotericin. Second, you can increase your aeration. So these are 2 things you can do. So this long therapy if you give, you have to face these extra problems.